Good morning, everyone. So, welcome to our session. It's a session which we just thought of the hat. It's on the art and science of communication. Happy patient, happy doctor. So, what are we actually trying to do in this session is we are going to try and discuss different scenarios where we as ophthalmologists face in our day-to-day practice, and how best do we counsel our patients during these scenarios. So, well, I'd like to introduce our panelists. Sir needs no introduction. So I asked him, sir, what is something which other people know little about you? He said he's married but happy. So I said, so that's most of us. Then Madam's not around, that's why. Then we have Dr. Nirmal Frederick. He's a wellness enthusiast, marathoner and cyclist. He's also a financial and career advisor to doctors. He also represents patients and doctors in state legal service authorities. This is among what else is written there. Then we have Dhanashri. Dhanashri, well, I need to talk less, but I can tell you that, yeah, she bakes well, that's her passion, and that's what we, like her brownies, and we keep telling her, make more of them. Lesser said the better. One of the most enthusiastic, smiling people I've ever met. Wonderful daughter Varshini, and the important thing is, Sir plays Ashy in the League of Legends, and that has made him ambidextrous. Sangeet needs no introduction. So he was with me in, when he was doing his fellowship. We were flatmates. Something which he loves is driving. He has a passion for cars, and he loves to drive. So whenever we go to Punjab, he just takes his car and says, let's go wherever you want to. And then Professor Vijay Shankar. Well, he is, his father was the illustrious James Bond of Tamil Nadu cinema. And like his father, he loves, very few people know, but he dances very well and he sings very well too.
Thank you. I think we have danced together. Yeah.
No, I've watched you dance. I couldn't catch up. And well, this is the most boring of them all. That's me. So, well, let's start with the questions. So, I'll be putting the questions forward to our panelists, and we let one of them, or the first question could be most of them take it. So, when you have a patient who comes to you in the outpatient whom you are going to advise a cataract surgery, what do you advise? What do you tell the patient whom you are going to advise?
Okay, I'll start off with the basics. First of all, when a patient comes to you, to your OP with a cataract, and you have to advise him, most important thing which I do is I tell them that it is not a disease, it is just an aging process. And because of that, your vision is down, and this process is reversible. It can be reversed. And 99.9% we remove the cataract and we'll put the lens for you if everything is fine. And I tell them about the stage of the cataract, what they have, and I always give them a lot of confidence. Tell them that it is just, it is one of the signs of aging, which can be reversed and they can get their vision back.
So they'll tell you, is it a very safe surgery?
Yeah.
You tell them.
Yeah, I always tell them 99.9% it is a safe surgery. Yes, and we remove the cataract and put in the lens as per their choice and as per the specifications of the eye, if there is no retinal disease and all that. And I also tell them if there's a white cataract or or a very hard cataract, grade 4 or 5, I always tell them that, look, there are chances where I may not be able to keep the lens in the first sitting, and I may require a second sitting to keep the lens. So, but I don't stress on that basically. I give them confidence, otherwise they would run away.
So basically what we have in our panel are people who are private practitioners, very successful private practitioners. Everybody is successful, very successful. That's why you all are here. But from different parts of India. Vijay is in Chennai, Dr. Muscati is in Bombay, Dr. Nirmal and Dr. Ramesh Raj are private practitioners in Chennai. Sangeet is in Tind Eye Hospital, and Anushree and me are at Shankar Netralaya. So each of us have a different way that we would be explaining to patients. So what we are trying to find out is what difference do I say and you say, and what is the best thing that we should be actually saying to the patient.
Dr. Sangeet wants to add on something.
Yes, Sangeet.
Regarding the safety part, I always tell the patient that this is one of the safest procedures that is performed on human body. So I think you just have to convey that it's very safe.
Yeah, there are two things. One is if a patient comes to you with a mature white cataract or a black cataract with PL vision or something, the first thing I do is reassure them. I ask them what took you so long, because this is a city practice, so there must be some fear in their mind by which they have been avoiding it till the patient became PL. So I need to find out, once I've ruled out that there's nothing else, no pathology, it's not a blind eye with optic atrophy, then I ask them, what took you so long to come to me? What are your fears? So I try and elicit that out of them so that I can solve it. Otherwise they will simply be going to the next surgeon. They've possibly been avoiding the surgery.
Very good point.
So that is the black or the white cataracts. If a patient comes to me with 6'9" or 6'12" and has got significant cataract according to me, I tell them, and no one has told them this because many of my patients are tertiary, I mean they've seen others. But if it's a naive patient whom I'm seeing for the first time with 6'9" or 6'12", I tell them that, you know, you've got something called a cataract in your eye, and as he says, we explain what is a cataract. And whenever you feel that there is, you're not happy with the quality of your vision, do come back to me. Otherwise, come back and see me after a year or after 6 months or whatever for a routine checkup.
Yes, sir. Dr. Nirmal?
That is another problem. That patient comes to you and says that I want a cataract surgery. He's having 6/6 vision. So we have to advise that this is not the right time for you to get a cataract.
So what I tell them is there's always a risk versus benefit ratio. So they say, do I need a cataract surgery now? I say you cross the bridge when you have to. You cross the road when you have to. There are risks involved. But when
the problem is that sometimes they've been to an unscrupulous doctor before coming to you, and they don't tell you this. That person has told them that by today evening, if you don't operate tomorrow morning, I can't guarantee.
Oh, yeah,
and this patient has got 6'9" or 6'12". So sometimes you may not even tell him that there is a cataract. You know, you just change his glasses, give him 6/9, 6/6. And then he comes out with that loaded question, doctor, can it wait till tomorrow because the previous doctor told me this.
Yes.
Now you want to defend a colleague but you find it difficult. So there I tell them, look, the previous surgeon in his experience, what he felt was that you have an operable cataract. I don't agree that we can wait till tomorrow, it can wait for 6 months, it can wait perhaps for 5 years. So I deflect what that person is saying because it is terribly wrong thing to scare a patient. But this is what I tell them.
Sure.
Yeah, that's wonderful, sir, what you said. Because second opinions are happening everywhere now. And I've had patients with 6'6" coming and telling me, sir, the doctor said the cataract will burst today night.
Yeah.
So I tell them nothing will burst, only a balloon will burst, don't worry. And you will be fine, come back to me after 3 months.
Dr. Nirmal, you want to add?
Yeah.
Just to add to that, I also add the risk factors for the patients. Suppose he's a diabetic or elderly who has a risk of fall. So we need to explain those risks as well, because many of them tend to feel that at present they are good. But we have to explain to them about the future prospects also. Worsening diabetic retinopathy, worsening cataract, and the fall risk. It's always a high risk of fall in elderly.
Yeah.
So highlight that also.
So you tell them whatever vision is lost because of cataract, that vision will come back. What is lost because of your retinal issue or those things will not come back. Do you tell them that you will place a lens all time? I tell all my patients that 99.9% I'll place a lens in the first sitting. But if I feel it is risky, I take all the onus on me and say that if I feel it is risky and if your support is not good, I may not place a lens in the first sitting, in which case then we may need a second surgery.
No, generally, many of these patients have already seen 2 or 3 doctors. So they know about lens. So it was maybe a decade back, there was a question whether you have to place a lens. But
yes.
now it is taken as granted. So we tell them the alternatives, right? So there are a lot of methods of where to place the lens, whether it is within the bag or the sulcus or any other options. What is best for you, we will choose depending on your risk factors.
Sir?
So, most of my patients keep coming back to me for a very long time, and I look at their complaints. So I always make it a point to ask them, what troubles you? Why have you come today? What's your problem today? And if they say they come for watering or itching, I will only take care of that. Okay. Even though they have a significant cataract. But if they say they can't read or write or watch TV or they have some vision complaints, then I will advise cataract surgery. I have a slit lamp camera fixed onto my slit lamp, so I always ask the attender, the husband, daughter, somebody to see the lens changes, the cataract, and I compare both the eyes. So they know there is something there, and I show my 20D lens and say, this is how you were when you were young, but it has changed color now. And whenever you wish, you can have it done. So specifically about risk and complication, I will only mention risk and complication. There's something abnormal with the eye, but not for a normal patient. So if they have severe issues in the eye, I will tell them you may need some extra procedures. But 99.5% of my patients, I won't talk about risk and complications.
So this is something which we used to do in China also. We had a slit lamp camera which was attached, and all patients would be shown their photo and told that this is a cataract and you need the surgery. So if I have a patient who has cataract and less vision, but they are not complaining of vision loss, I tell them you have a cataract, so you'll have to decide when you need to go in for surgery. It is significant. So if you plan, you'll see better vision. So I just tell them that much.
Yeah, one small point I want to make is in my practice, I have quite a few people from the upper strata coming and asking me, sir, is lens required for cataract surgery? Can we do it without the lens? What will cost with the lens, without the lens? So we have all these funny questions still happening, sir.
Okay, next for the two retina surgeons here. So you have a patient who comes to you with, say, a retinal detachment, needs surgery. What do you tell the patient? Yeah, you can take that.
Retinal detachment, there is no doubt about it, the surgery has to be done. But what you have to inform the patient about the prognosis, because often the patient's expectations are very high. And we know that the retinal detachment surgery, despite your good outcome, the visual outcome may not be as good. So it may not match the anatomical outcome. So never promise the patient a very good outcome. Always keep the expectations low and let the patient know that even with despite good anatomical outcome, the vision may not improve much. So don't raise their expectation much, and always prepare the patient that they may need a second surgery.
That's from the institute point of view. Now we'll hear from Sandeep.
When a patient comes with the RD, to me, first thing is I take a fundus picture. I show that to the patient that this is wrong with you and you need surgery, that is definite. And two things I tell them that you have to keep in mind. One thing is that the surgery is not always successful. Almost 80% retinas we can attach, 20% we can't attach, right? And even if you attach, you are not going to gain very high vision. The main aim is to protect your eye from going blind. And you may gain vision, but it will not be 100%. The second thing I tell them is, I always tell them that you will need multiple surgeries. I never give them an option that you may need a surgery. I always tell them that you will need a second or third step, which may be done 1 month, 2 months later. And I think, and then we take a proper consent. This all is videographed and is taken as a consent. And
you take a video for all patients. So you have a camera in your room.
Consent, yeah.
You have a camera in your room when
Yes.
you are talking.
Yes.
So do you take a consent from the patient that we are recording in?
Yes.
Okay.
Yes.
That's very nice. So from the cataract point of view, you can be very truthful to the patient. Tell them that yes, these are the pros and cons, and this is what we are. That's why we are advising you surgery. For the retina, the same thing. What they have just said. Anyone wants to add? Dr. Kumar, you want to ask? Yes. That we told you. That we told you. Yes. Yes.
No,
Yes,
this
sir.
is called as the care plan, right? I think most of the NABH accredited hospitals would know that when we talk to the patient, we have to write the
probable diagnosis or provisional diagnosis, then the advice for that particular event, for that particular discussion we had, and then the care plan, what we are going to do in future. What is the discussion points with the patient. So that helps in medical legal cases. But it also helps us to remember about the patient when they come back after a long time.
Yeah. Yeah.
So, I had a patient 6966, said you have a cataract, gave all the explanation. Then he took 2 opinions and he sent me a letter saying return my money. I've been to 2 doctors, both have said I don't have a cataract. So I told him, okay, send me the picture of the diagnosis of both the doctors. To my luck, one doctor written both has cataract, another doctor written both has lenticular opacity.
Okay.
Kumar,
Yes, sir.
Kumar, I have a remedy or small camera which is fixed onto my slit lamp, and then whatever I am seeing the patient's relation can see, I ask him to take a photograph. Any patient who has a doubt or asks questions which you feel they don't trust you, ask them to take a photograph of what they are seeing of the lens. So in there, even a 6S cataract with early lenticular changes, it shows up a slight green layer. So they will know there is some changes happening and you are fully covered. Once I started using this camera, it's only about a lakh attached here. It makes a very big difference. There's no question of doubt. They see what you see. They see the foreign body. They see the lens on the post-op day, clear cornea. So our discussions are much more open.
Your conversions also increase. The surgical conversions, once they see the cataract.
Surgical conversion, I don't like to convert because in my time I want to limit my practice.
Sure.
But the patients are totally convinced, yes. And
Yes,
it helps
sir.
them to take a photograph.
So regarding early cataract, whether to speak, because I encountered a patient, he happened to be a distant relative, and he was 52. Nowadays we get 50, 52 early cataract. He had early nuclear sclerosis. The moment I said, he was taken a shock. Doctor, at this 52, how can I have cataract? And it's just early, nothing to do. We'll just see 1 year back, 1 year later. Now this patient went to another ophthalmologist for a second opinion, without telling me. He's being my distant relative. That ophthalmologist called and told me that such and such. Now my practical question is whether those early NS should we inform the patient or should we not inform?
Yes, be truthful.
Yeah.
There's no question of being hiding. Even if it's a relative, they get sometimes more difficult. Close relatives will just keep quiet and listen. It's the distant who will still have a little shock. So you should be absolutely truthful. That you have a cataract, if you're not having a problem, wait. If you feel that you're not having a problem.
I will not inform if the patient is not symptomatic. If he's absolutely fine and he came for something else and he has normal vision, I will not inform him he has got an early cataract. With our current slit lamps, even a 25-year-old has got early lens changes.
So we'll go on to the next question. Patient comes and says that, do you generally tell them which type of lens to offer? But do you always put that as a monofocal first? But the patient comes and tells you that no, I do not want to wear glasses. What will you tell this patient then? Yes, Dr. Suresh.
Yeah, so basically I tell them that there are 2 types of lenses. One is, forget about the toric part, but assuming that there is no toricity, there are 2 types of lenses. One is called monofocal lens, which will correct you for either distance or near, and the other is multifocal, and they're first cousins from the mother's side and father's side. And then I ask them to choose either of the 2. So if the monofocal is chosen, the matter is over. If it is the multifocal, then I give them the other, the choices between. Then we go deeper into the thing. But I tell them that I wish I could ensure that you will not wear glasses. Unfortunately, I am not God. I will, as per current technology, we will try and make sure that the need for glasses will be minimized. But assuring you of not wearing glasses is out of the question.
So you tell them that you may need glasses before. So what I tell them is you get a cut in one hand and get a cut in the other hand. each may heal differently. So where your wound heals will tell us what the final power is.
That's a wonderful point. Now, one thing I always tell the patients about multifocal lenses is it is a means and not the end. We don't have the ultimate multifocal lens which will correct your distance, middle, near and all that. See, every year there are new lenses coming, and whatever is best in the market, we are sure we'll do it for you. And after I check the patient fully and make sure that he's fit for multifocal, I also tell him that he may have, I ask him about his lifestyle, whether he drives and what his nature of work is, and tell them that he may have a glare or halos, or he may require glasses. That is always mentioned, which I show my patients also in the consult basically. So these things have happened. We've had unsatisfied patients with multifocal.
All of us.
So it's better to be truthful.
Yeah. Sir?
So for patients who have retinal pathology, I generally advise them not to have multifocal IOL, because it becomes difficult later on to treat or do the laser or do the surgery. So preferably monofocal, and also they may not have the full benefit of the multifocal if they have some retinal pathology. So in those patients, I think better to stick to monofocal.
So my question to you is, do you find it more difficult to do your procedures through the multifocal lens?
It is a little difficult to image the retina. So while doing surgery also, you may not see it very well. Doing laser also becomes difficult. Not that you cannot do, you can, but it is difficult.
I don't do multifocal lenses. Two of us operate in my clinic, and we do about 800 cataracts. We do monovision, so we'll target distance for the first eye and near vision for the second eye, depending on the patient's needs. I don't think I need to do multifocals to grow my practice.
So what percentage of, you don't do any multifocals? Okay.
1 in 3 years.
Okay.
Okay, I think then I have to take Ramesh for a dinner to refer his multifocal patients requiring multifocal. See, there is an option.
I send them to Arul, by the way. Those who need a multifocal and they want it.
Please start a practice in Tambaram.
I send them to my friend Dr. Arul, who is a super multifocal lens implant surgeon, and he's quite happy with them, and I'm quite
So
happy.
that's what sir is saying. He's taking you out for a dinner, send some to him too.
Okay, so there are two ways of looking at it. So one is, we have to tell what the options available now, because somebody tells the patients we are not fulfilling his need or demand. Second is his requirement. So very often we see elderly people, I don't want to wear glasses. All along 20 years I've been wearing glasses. I need to talk to my grandchildren. I need to mail a lot. I need WhatsApp. That is the major requirement nowadays. So in that case, we tell them that this is the option. If you can afford, or if you are confident about this, go for it. And we also have some patient videos, testimonials about the lenses, as well as to address the fears and the queries. So we play those videos to the patients. Instead of listening to us, when they listen to the patients and their opinion and their feedback, they are satisfied.
So you have made these videos?
Yes.
So you show them, or does the counselor?
Counselor shows them.
Counselor.
We have a doyen of ophthalmology, Dr. Sohan Raj. He's got a point.
Whenever the patient comes for an eye checkup, I see, and if I find that he is getting a cataract, I'll tell them that the cataract has started and you are having loss of reduction in the vision because of the cataract. If you are happy with the present lifestyle, if it is not interfering with your day-to-day work, you wait for some more time and come for checkup. See, all the patients who comes, I dilate and see, and that is shown in the camera, what is the extent of cataract is having. Coming to the multifocal and the monofocal, first thing I ask about is occupation. How many hours he has to drive, how far he lives, and do he drive every day in the night or only. So then if he says whether he wants to have a glasses or no glasses after the surgery. The occupation, when I put a multifocal lens, I tell him that you will be able to do everything what you for your lifestyle, but for particular if you want to thread the needle, or if you want to read the rate of the shares in the market, or you want to have a read on the medicine bottle, what is written there, you may need glasses. If it's depending upon that, I advise you to go for the what type of lens he has to.
Yeah.
Thank you. Thank you.
EDOF meaning?
Many people call EDOF as monofocal plus, so it's just nomenclature. If you don't want to tell him, don't tell him.
No,
so you're talking about the symphony or you're talking about the eye hands? Yeah, the eye hands is monofocal plus. So we'll come to that.
Yeah, we'll speak about it. It's a boon for the patients with retinal diseases and all that.
Okay, the next. Yes. Yeah, so if it's a eye hands, I tell them, I don't do, my chair time is not changed with using eye hands. But if I'm putting in a symphony or a synergy or a panoptics, then yes. So what about this? You have a patient with significant astigmatism. You're recommending a toric intraocular lens. What do you tell the patient? Nirmal?
So we do the basic assessment and also have the biometry report in our hand. Tell them you have this corneal problem as well as your cylinder power. This can be corrected, right? So there is a financial addition to it. If they are happy with that, we go ahead with the toric. Otherwise, we tell them about the monofocal.
So if they tell you, do I have to put it? Then what do you tell them?
Now give them the choice. See, there are two ways of correcting it. One is the monofocal, regular, and you may need glasses additionally later on. And another option is we can correct during the surgery by placing a toric lens. So most of the patients, before it comes to us, they are counseled about all these things. So when they hear it for the second time, they are more open for the ideas.
So I tell them, yeah, you have a corneal astigmatism, so we can correct it with the intraocular lens. I tell them with the intraocular lens, it's closer to the nodal point. I don't go to explain what the nodal point is, but if I just tell them nodal point, most of them will just nod their head and say yes. So I say that becomes, so your vision will be a little more crystal. The only downside of it is that these lenses have to be placed in an axis and these can move. And they generally occur in the first 1 week or so. So if they move, I need to take you back to the operation theatre to redial them. So I tell this to all my patients. So I don't, if they are, say, those who are not systemically too well, then I don't even try to push a toric to them. So you?
So this comes under, I have 3 packages. It will come under the 3rd package. So if the patient asks me, should I choose it, is it good for me? I'll say yes, please go ahead, it's good. And if they are doubtful and they ask questions, this is the way I approach. If it is like 1 cylinder in the, and they have to correct it and it's against the rule, I'll tell them it's like 10%. This is what the nurse will tell them, the counselor. So 1 cylinder is 10% sharper with a 1 cylinder toric lens, and 2 cylinders 20% sharper. And if it's a 0.5 cylinder, it is 5% sharper. So I'll tell them it is like 10% sharper, and then they can make a decision whether they want to pay or not, pay more or not. So we have some patients who cannot afford to pay and who will choose the basic package, but they have something like a 2 corneal cylinder. It will make a very big difference for them. So for those patients, for a basic package, I'll put a Indian toric, and I will not tell them. So we expect them to see well.
Okay. So if these patients, if the lens moves in the early, then what do you do?
Vinith, lenses don't move. If you sorry, my lenses I'm so sorry. I have re-rotated once, and I have had 4 or 5 where I feel
How
I
do you
should
mark
have.
them then, sir?
I take
On
them
the slit lamp?
on the slit lamp. I have a disposable needle. I do a single mark on the axis, and it's very unusual to be more than 3 degrees off in the majority of your patients, and infrequently it will be like 5 to 10 degrees. That's very, very rare. So choose only Alcon torics and use Helon because it takes a long time to remove all the remaining visco. And I have one of my old slit lamp which is no longer good for OP use. It is there on the OT, on the corridor. So patients is there, I have to come out to the semicircular corridor, I'll mark and I'll take them in. That's it.
So we too mark with the slit lamp. So
But I guess you're also using the Alcon toric. What percentage do you have
to? Technis toric.
No, Technis toric rotates minute. It's not as good as Alcon.
Why that rotates?
Yeah, it does. It does.
So there is a chance of
There's a very big
rotation.
chance.
there is a chance.
No,
yes.
No, off late, I think the lens technology has matured. So we don't get to see those rotations nowadays.
They are very rare, but I tell my patients for that tomorrow if I have to take them back to the operation, I'm more comfortable doing it in the operation theatre. So I tell them that we have to take you back, and that becomes an additional cost. So that they need to know, plus the stress. So there's one incident where I had one patient whom I put it moved around, I think it was 10 or 15 degrees, he had a 0.75 residual. I took him back, that went the other way now. So I had to take him back the third time, but since third time it sat well, so I had to tell him. So, but he was fine with it, as long as your communication to him was open and you could tell him that this is what it is, that's why I have to do it, they are fine.
Yeah, we don't charge for those second procedures, so patients are really happy with that.
You don't charge.
Even for,
So we can't, we have to. So Dr. Badrinath at SN was very clear. He says that these are things which you tell in advance. It's not your mistake. You have put it in position. Why wouldn't you? We have a Varion, we do a marker with a slit lamp, but still you see that sometimes it's moved off. It's like not charging is accepting guilt, which is not your fault actually.
I think it varies from an institution and a private practice.
Possibly, yes.
Yeah. Here you want to retain that patient, so you don't charge. You absorb that incremental cost. And as all the other speakers have said, actually that split lamp marking and all we are no longer doing. We are using an app-based marker, which is I think superior to those dots which we used to put on split lamp. But whatever you are using, the incidence is not worth the chair time of telling the patient about movement, because I'm not going to charge him. And if at all it comes, that I tell him, wow, you're really an unusual patient. So many patients have done, you're the first guy that has actually moved. Don't worry about it, 5-minute procedure will take you back inside.
Okay.
You know, that's so they're accepting.
Yeah. That's a nice way to go about it.
And I'll go with Ramesh sir, alcohol toric lenses are fantastic.
We won't go into that discussion.
Yeah, we won't go into that.
I think one thing is very, very important, that if you have a toric IOL, you have to look at the posterior float of the cornea.
Yeah.
If you are not doing that, don't do toric IOLs. Because one day, the way I learned the lesson was, my toric IOL patient became very unhappy and he had a keratoconus. So that was many years back. So now we do it as a law. One is that. Two, I learned recently at the ACRS, toric IOLs, if they rotate in 1 hour.
Okay.
So majority of the US doctors are keeping the patient who have undergone toric IOLs for 1 hour in the clinic, checking and then letting the patient go.
Okay.
This I just learned at this ACRS in San Diego, which even I didn't know, because all of us just do the surgery and send the patient off. And as he said rightly, I don't want to get into a discussion of which company, I must have rotated one toric IOL, which was a Zeiss plate haptic, because it is dependent on the size of the bag. So none of the other torics really need rotation. In Mumbai, we don't charge, as sir said rightly. You know, you're the first patient. It may be your 5th patient, but for him it's the first time.
First time. Okay, so can we move on to the next question? Yes. So during
many times it happens that we explain the patients that by using toric lens you will not need glasses for distance, but the patient forgets. He remembers that I actually don't need glasses for near also after that, because you have explained that patient that by not using toric you might need glasses for distance. For near you are going to use glasses, but we explain them by using toric, so that problem
they say that we are spending extra, we have given more money, so we should not be able to read. Yeah, so that's why you need to tell them. I've actually stopped aiming at plano for distance. I always aim -1, because nobody watches TV now. You can drive with the -1. Everybody wants to see the phone in the morning, first thing, and if they can't, they see, I can't see. You've not done a good job.
But mention this in the consent. So take a written consent which suppose you're putting a monofocal toric, that you will need glasses for reading, and get him to sign that, so that tomorrow he can't forget, it's there with you.
So this is the next question. Sir, this is for you. During surgery, the patient develops a posterior capsular rupture without vitreous loss. So do you inform the patient and the attendant? If so, what do you tell them?
Not at all. They don't know what a posterior capsule is. They don't know what vitreous loss is. Why do you want to confuse them? You have a PCR, you put the lens in the bag, patient is fine. Why should we tell them anything? I will not tell them.
Okay. Anybody else?
If they have a doctor who is watching, I will demonstrate. Oh yeah, you have.
So I tell them that the support wasn't so good, but no problem. We managed to put a lens. Everything is good. Nothing to worry.
Yeah, I also tell the patient
I
that
tell the
support
patient.
wasn't strong.
After surgery,
Yes,
I come.
yes,
and
madam.
I have a question on this. That will you put always, if you have a PCR, will you put a 3-piece or would you put the foldable lenses in the bag?
That depends on the type of PCR.
So this is without
many
vitreous loss,
PCRs
madam.
are very small, and you can put your standard lens within the bag. Only if you are having a disorganized posterior capsule, you have to put in the sulcus and do an optic capture. But at that situation, you've probably done an anti-vitrectomy also.
Yeah. So
just a
that's the
small
next
PCR
question.
you will.
That's the next question. Vijay, this for you. You have a patient with a posterior capsular rupture with vitreous loss. So then what do you tell the patient and attendant?
Yes.
When do you tell them?
Yeah, that is when there is a posterior capsular rupture with a vitreous loss. After the surgery, I tell the patient that, look, intraoperatively the patient asks me, sir, you told me so much time, it's taking more time than what you said. Because everywhere else you're doing it at a few minutes. I tell them, no sir, I've encountered an issue here. Your support is not very strong. So I have to manage it. I will keep the lens. I'm just give me some time, I will talk to you after the surgery. Now after I finish the surgery and hopefully I keep the lens, I call the patient and attendant and I tell them that, look, your support was not very strong. So I had to keep, I managed to keep the lens, it went off very well luckily, there was no problem at all. And it took some extra time. Patient may see some floaters tomorrow, they have to see some black spots, but it will all come down, he'll do very well. First of all, reassuring the patient is very important, because initially when I started practice, when I've had PC rents, I've had patients, I didn't tell the patient that they'll have these floaters and all that. Next the patient rushed to me, sir, I see black spots here and there, I'm so scared. So I always tell the patient, look, you will see this, it will settle down. I reassure. It's all about reassurance basically. And tell the patient that you have done the best for him. You have done your best for him.
So that's what I do. I would also tell the patient that yes, your support wasn't good. So if I had planned to put a 3P, say a multifocal or this one, so I would have already told them that I'm going to do what I think is best for you. So that decision is mine and I take that on the table. So if it is a 3-piece which I'm putting instead of 1 piece, then I tell them that lens was not safe in your eyes, so I have put a lens which I think is safe for your eyes. And yes, if I have put triamcinolone, you will see a few black spots, a few cortex goes down, you may see a few black spots, but that's generally clears up. The retina people, Nanashri, if you get a patient who comes like this, what do you, or when you do cataract surgeries and VR patients, what do you do?
Yeah,
they are very happy. They want a lens drop. Then they are more at home like.
Husband-wife secrets.
So actually, yeah, as a VR person, when you are doing vitreoretinal surgery, you are a little bit more at ease because you can manage all the complications. Even if there is a nucleus drop or PC rent, vitreous loss, everything can be managed. Even if there is no capsule, also you can do a scleral-fixated IOL. So that is not much of a problem. The end result is okay, but I always inform the patient what has happened and what is the final outcome. So as you said, definitely I tell them that this was the best thing for you and we have done whatever is the best. So if I have done scleral fixation instead of the normal IOL, I'll tell them that we have sutured the lens inside.
So the next question. So you have a patient who...
Before that, there is a third variation of PCR without loss, PCR with loss, and PCR with a nucleus or an IOL drop. So in that case, just to go on from here, of course you have to tell them, and you have to tell them why in private practice I have not gone further and I have closed the eye without putting a lens, and what the next step is going to be, how my vitreoretinal colleague is going to tackle. All that is told to them immediately.
Yes, sir, we are coming to that. So you have a patient with pseudo-exfoliation. So what are you basically going to be telling the patient?
Yeah. When a patient comes to you with a pseudo-exfoliation, first of all, explain to him, when you first examine him, you explain to him that the issues which you could encounter while doing his cataract surgery. You could please tell him his pupil may not dilate very well, and about the eye pressure issues, and also the capsular support may not be very strong. Weak zonules could be there. So all this could be told to the patient. At the same time, not to frighten the patient, tell him in a very, in a very mild way, saying that we may encounter some issues which can be tackled, which can be solved. That's what I do. I tell the patients these issues are there and these can be handled. So don't worry. It is our problem. We will handle it.
So I tell them you have some white deposits which are there on the iris and the lens, and these deposits can cause your pressures to rise. So you need, if their pressures are normal, you do need regular follow-up for the rest of your life. But these also have issues where the pupil may not dilate too well, and the support of the lens may not be too good, which I will have to see on the table. Final decision I will take what is best for you. Once you take the onus on yourself and say that I'm going to do what is best for you, that's my decision, I'll do for you what I would do for my parents. Most are very smiling, happy and say fine, thank you.
Yeah, it's reassurance. I used to tell white spots. So the patient told me, yes sir, I know it's the cataract.
Anything else?
Most of these problems, when you show the picture, patient understands.
Yes, so that's important. That's another thing which
that's
we can start
having an imaging system and camera.
Yeah. Yes. So if I see on the, so on the table when I see is when I tell them, even if it's say 6 to 7 millimeters, I tell them I may need a ring. So the initial cost is told. For us, we are in an institute where Dr. Badrinath was very clear that what you are doing, you have to tell them.
Kumar sir, beautiful point, sir. We have to tell the patients before, because otherwise they take it badly, sir. Even affordable patients, they take it badly.
But Vinit, I have a different point of view. My
Yes,
patients can't understand pseudo-exfoliation, they can't understand zonules. So if I have to explain, I will ask their sons to Google and read about it. I'll take a screenshot on my EMR. I will ask my nurse to Google pseudo-exfoliation. Whatever comes, they will take a photograph and send it to the son or daughter in the US. They will read about it. But the patient, my treatment plan will change. So in these patients, I will do a phaco, put a 3-piece lens in the sulcus and do a posterior optic capture so that I have extra support from the sulcus. So my treatment plan will change. But I don't tell the
all
patient.
patients of pseudo-exfoliation?
No, it depends. Once I go in, I will know very well whether this is going to last for the next 20 years. So many of these patients are going to have a drop lens in their 80s and 90s. And we cannot predict. So they're 70 and everything is fine. I'll put the standard lens. But if I had a doctor who was like 84, he came in a wheelchair, he's still practicing, dense NS, pseudo-exfoliation, everything gone. So he is very well off. But I put a 3-piece lens in the sulcus with the posterior optic capture to just stabilize it further and I left him. So that's a very basic lens. So my treatment plan will change, but I don't explain all this to the patient, they don't understand much.
Madam, you do a lot of glaucoma?
Follow-up.
Because your lens might fall at any point in time. I've just done a case which I put in the GSI2 where one eye patient, the entire lens was subluxated and he had immense advanced glaucoma and everyone was writing that, okay, shall we do a trial or not? I did the trial. It's worked very well. Past 2 months.
Fantastic.
One can attempt.
So when you say, so you have a pseudo-exfoliation patient or any other patient and you need to place a CTR, the bag has gone off in one quadrant. When you tell the patient, what do you tell the patient?
So again, if you are suspecting this beforehand, if there is a pre-existing zonular dialysis or whatever is different, or if you have created one. So if it's pre-existing, I normally charge a little premium on these type of patients, those who are pseudo-exfoliation. And I don't charge extra for putting in rings and all that. So if I don't put a ring or something, that's extra profit for me. But otherwise there is a premium already charged in which it's taken care of. But if this occurs on my part, then of course there is no extra charge in private practice. You do whatever you need to do. You put a ring, you put a CTR, whatever you want.
In private practice, as Ramesh says, one of the most important people is the patient attendant. You have to make him sit down and explain everything to him, because he can make it or break it. The patient immediately after surgery may have corneal may not see properly. Attendant, son or daughter will say, Dad is not done a good job, the doctor. Otherwise, they will say he's done a very good job, he has explained to us already. So it's so important that we keep the attendant.
That's for everywhere, not just the private practitioner.
Yeah.
That's even for an institute practice. So when actually a patient comes into my room, I would greet, how are you? And I tell the patient also, how are you? Patient's attendant also, how are you? You can immediately see the smile and they will start
It's so important.
warming up to you.
Yeah, we need a tongue for myself.
Most often the attenders are the payers. Of course, now it's changing. Insurers are the payers. We have to keep them happy as well.
So
the number of relatives that the patient has is directly proportional to the complications that you have created. Because suddenly you find relatives coming out from New Zealand, from Canada, from remotest village in Mexico, ringing you up at 3 in the morning. What has happened to my patient? You know, so.
Yeah. So in our institute practice, we have to charge for a CTR. So then we tell them that the support, the zonular support was not good. So I had to put in a extra support to keep the bag in place. But I'm more like Dr. Ramesh. I would rather put a 3-piece in the sulcus and do an optic capture. I don't like CTR too much. So
Next one.
Thank you for saying that,
Yes.
because when you have big zonules, there are two types. One is progressive, like a pseudo exfoliation. CTR should not be used. Only when you have a trauma-induced zonular loss, a CTR makes sense.
Yes.
So CTR will actually weaken it, and it may decrease the number of years it is staying.
So I'm not a big fan of CTR. But, so when you place the lens in the sulcus, Ramesh sir, you don't inform. Nirmal sir?
Now I inform the patient.
You inform. What do you tell them?
It's a weak support, so we place the lens differently, different type of lens.
Oh.
Yeah. The same power but different type of lens.
This will be covered in the pre-op planning itself. So pre-op, we will tell the patient.
Same lens, different position.
That you will decide what is best for the patient.
Yeah.
So even I tell all my patients that final decision I am going to take what I think. I keep specifying that I think is best for you. So I tell them that. So then you have a patient with a posterior polar cataract, where there is a high risk of a young patient. So yes, sir.
So my treatment plan is totally changed after I got the AIOC 700. It gives you an anti-segment OCT of the posterior capsule. 95% of them will have a nice, smooth curve, normal posterior capsule with a nice PPC. In those patients, I don't tell them anything about it. Only when I see a bulge or something abnormal in the posterior capsule on the AIOC 700 picture, I will tell them they have a posterior polar. So I expect 95% of my posterior polars to have a normal outcome. So I don't talk to them about it.
So what about those 5%?
I have a few pictures, they're very rare. You can actually see them. You can tell them pre-op, and I will show it to them that you have a small dehiscence in the posterior capsule, bulging. It's likely to break. We won't be putting any of the toric or the premium. You may need to have a vitrectomy done. And my surgical steps will all change.
Sir?
So I am not as good a cataract surgeon as the others on the panel, so I will tell every patient of a posterior polar cataract. I don't do the IOL master, so I will tell them that you got something like this, and the chances of something going wrong on table are high. So I tell them this in advance. I tell them about the anterior weight. I tell them about the chances of the lens not being put in the bag. All this is told to them, and of course the charges go up a little bit.
Okay, so I'm with you. Our charges don't go up. I do exactly the same. I tell every patient that you have what is known as the posterior polar, which is generally the support of it is weak, and the lens may fall back into the vitreous, and in which case you may need a second surgery to remove it. I am back
for those who are not in institutes and who are in private practice, please don't hesitate to increase your charges, because it's your blood pressure which is going up, it's your tension, your stress. You're dreaming about this patient for 2 days as to what will happen. So you need to charge for those things. So whenever there is it's not only for premium IOL that you charge extra, but when there is a premium cataract, a cataract which is causing you stress, you must charge a little extra for the effort that you're putting in to make sure that everything goes well.
Other than patient risk assessment, we have to do surgeon's risk assessment.
So I wish you tell our management that.
Everything, yeah. Everything changes. Yeah.
Yes, it's just totally amazing. It's amazing. It will give you an anti-segment OCT picture just below the printout if you like. Or my nurse does it, or my optometrist does it. So they will come and tell me, PC intact, all PPC. When they see a flash, they know it's a PPC. And they'll come and tell me PC normal. Or they'll say it looks abnormal and they'll ask me to see it. Basically, they'll take a photograph in their phone and they'll send it to a WhatsApp to me. Yes.
No,
so
AIOC2023
must be 700. Yeah, any AIOC2023, but easy to have an 700. It has totally changed the way in which I approach posterior polar. Earlier it was a mystery. Now it is very clear. 95% of them have a normal posterior capsule, and you can do your normal surgery.
So you've done and you have this epinucleus and cortex in the vitreous. Now what do you tell the patient?
I will do an anterior vitrectomy.
But then
as
maybe
long
still
as
some which are too deep
yes,
to remove.
in those which I don't remove, I will definitely tell them exactly what you said. That a part of the small bits are left back inside. They will absorb in several weeks or several months. No worry at all. Don't worry.
So if you have a little larger chunk of cortex, then what do you tell?
We need 15-20 years.
You haven't had
Okay,
so
I'm sorry.
I'm not that great a surgeon.
So again, confession, I'm not that great, so I've had all these complications and more. So I will tell them, obviously I tell them that I tried hard to remove your whole cataract, but your pupil came down so much I could hardly see things inside. It is possible, and almost 100% that I've left some things inside. We'll wait and watch, and then depending on what I find later, I'll tell you what we're going to do, but we'll need another procedure.
Absolutely. But absolutely truthful, tell them that this was the thing, that there was a small part which has gone back. If your pressures don't rise or your cornea remains clear, then we don't need to do anything. But if your vitreous starts having some opacity, then I may need to refer you to my retina colleague to remove it.
Go ahead.
Okay, so this one. So you have actually a nuclear problem, the same thing, and you have to communicate this to the patient. So you have left the patient a fake kick. Now what? What do you tell the patient?
So this is a very difficult situation because the patient is not expecting this, and unless it's part of a pre-op plan and you have already discussed this, so you have to tell them that you could not put the lens inside. It is not safe to leave it, but we will do it again after the eye is quietened down 2 or 3 weeks later. And sometimes it will be done along, I guess, with the nuclear drop situation. So in that case, I'll refer it to my VR surgeon or colleague. He will do both.
So you have a dialysis, so you've probably used the Vectis and removed the whole total white cataract. A black cataract.
You mean a retinal dialysis?
No, zonular dialysis.
Yes.
And you have removed the whole, because you can't leave that.
Oh, you want to know how we'll handle it? I will do an anterior vitrectomy, and I'll put a AC lens inside.
You'll put an AC
lens, and I will tell the patient that I put a different kind of lens because the membrane supporting the normal lens tore during surgery. It was too weak. I never tell them I tore it. I told them it was too weak and it gave way.
You don't have to say you. It happened.
It happened.
You don't have to say that I did it. I didn't do it. I was trying the best for you.
So post-op, I will show them the AC lens in the eye or the slit lamp and tell them I put a different kind of lens and you will be fine.
Vijay, you want to add?
Well, in my experience, I'm not a big fan of anterior chamber lenses. I would always prefer SF-IOL. I tell the patient that that the support was weak and we couldn't place the lens system, but we're definitely doing it, and we'll have a VR surgeon doing it.
Okay. So same. Sorry?
I do that.
Whichever your choice.
I prefer exactly that. The iris tolerance would be IIS.
So like I have a VR backup, so for me it's easy. I just have to tell her, hey patient, this patient is coming, you just have to take care of that patient. Yeah.
They've been around several years now, the anterior iris claw was not as safe as the posterior iris claw. Retro one is very safe, very safe.
So this is for the retina people. So you have a patient, who's been referred a nucleus drop by an anterior segment colleague. As a VR surgeon, how do you handle this situation?
So Sangeet, in a way.
So you just explain to the patient that there is a complication, and not that you have to stress to the patient that there is
complication. I mean, what will you say? Say I've referred the patient to you. What are you going to tell them?
So we tell the patient that there is a part of the lens is there inside which requires to be removed, because otherwise it may cause some rise in pressure or inflammation, and this is a surgery which can be done easily, and we can also fix the lens. So
Doctor, why did that happen? Was there something wrong with the
you have to stress that it is not a mistake on any surgeon's part, or it is not negligence. I always tell the patient that, see, surgeons are very egoistic people, and they don't want their surgery to fail.
I have to refer to someone else now.
I just tell them that no surgeon wants their surgery to fail, and nobody likes that. So as a surgeon, if my surgery is failing, I don't like it. So I try my best to make sure that the surgery goes on well. So whatever your surgeon also must have done the same thing, but sometimes there are some situations which are not in our hands and complications may occur. So you have to make it make them understand what is negligence and what is complication. So you have to tell them that the complication has happened and this can be corrected. So we have to do a surgery and remove it. So most of the people, they would accept it.
So to an anterior segment surgeon.
See, the common question that the patient will ask is, Doctor, did he cause this complication? Was he careless in his approach? Could he have avoided this from happening? Suppose you were the surgeon, would this have still happened? So then he is leading me on. I said, yes, it could have still happened if I was there. The point is, I was not over there sitting in an armchair now. With hindsight, it's very difficult to know what happened. And as Tanushree said, that the surgeon must have tried his best. You come to me to find out how we can go further from here. We'll take it further.
Yes, yes. So very important.
One more thing which really helps me is, I'll immediately, my nurse will Google incidence of PCR in cataract surgery, and you'll get there WebMD, AAO, and they will say 0.1 to 2%. So they will read that. It's a known result of cataract surgery all over the world. 0.1 or 2% of cataract surgery will have a PCR, and they are seeing an independent online resource, and the attender, the son, daughter will read that, and then they calm down. Once they see a major review showing that, or Wikipedia also, PCR incidents, they become reassured. They will no longer say, why did you do, why did he do?
I also agree that. I also counsel them very extensively, and I refer studies. I in fact send them references. If they have some relatives in the US who are mailing me about their parents and all, I actually cite references and tell them to go through this reference and read on that. So it makes it definitely helps if you give the statistics and if you give some references and big studies. So it is easier for them to understand.
Absolutely.
Sometimes it is like almost like a PG class. The amount of counseling and amount of education you give to the patient and attender, I think the fellow learns just by listening to that.
Exactly.
I tell
100%.
an entire class on retinal detachment for you. This is
my last take on this, reassurance is the key.
The chair time.
Yeah,
the chair time.
Extremely important.
And explaining to them.
He is always worried. Sir, that guy didn't have, my uncle didn't have, auntie didn't have, how did I have it? So please tell them it can happen and you will be fine.
And we have to give them a care plan. This is what next. So they are more worried about that. So whether we are going to have the IOL or not. So what we have to do is
more tough, sir. I've added the patient also has a retinal detachment. Now what will you tell them? When you tell them that there was a lens which is fallen in and there is a retinal
and there's also another problem is there is also a lens sitting there. IOL which is put by the anterior segment surgeon, which makes the situation even more tough. Yeah, there is a nucleus drop, there is retinal detachment, as well as the lens sitting in there as a posterior capsular remnant. So it becomes very, very tough. But whatever it is, never blame the previous surgeon. That is the one golden rule that we follow in Changanetralaya. Whatever the complication, however the extensive complication, we never blame the surgeon who has referred or who has sent. we always explain to the patient that these are complications which can occur and probably some of them might have been pre-existing. So as Dr. Kuresh said, now what next is what we have to plan, and we plan the best way possible for you to come out of this complication.
That's the most important. Never talk bad about a colleague. Never. Whatever they have done, you were not there, you don't know what happened, but I'm sure they would have tried what is best for you.
And tell them they require multiple surgeries.
They would require. So what about an endophthalmitis? So you have a patient who, you're the operating surgeon, now what do you tell the patient?
So, go ahead. Ramesh, go ahead.
This is a very, very difficult situation. So I will tell them, if I suspect endo, I will tell them that I'm very, very sorry, but it looks as if the eye is reacting very badly. There's a very high risk that it's infectious. I will be giving an intravitreal injection right now in the next hour or two, and I'll send it to my VR colleague who will take care of you. I'll be with you till the whole process is over, and basically the remaining appointments will have to be cancelled, and we have to be with them. And I have the Arvind Hospital endo kit with me. There will always be one on the OT. So I will take it down. I will give the first dose, and then I will refer.
So why did the infection occur?
The patient asked me that. I'll say I don't know. I suspect it. We'll have to confirm it by taking a sample and doing some further tests, and that will be better done in the next.
Was there something that you did?
Patients don't ask me so many questions.
How are you so lucky, sir? See, I'm sure all of us have been asked these questions.
Directly,
very lucky practitioner.
Lovable practitioner.
No. I mean, I'll say I'm not sure, but I'll tell them I'll be with you. I'll be with you till this is sorted out, and I will tell you what has to, like care plan. Tell them what has to be done next. We have a major problem. And we will take care of you, and this is what has to be done next. And I will cancel the OP and take care of them.
We need a sorry.
So there are two, when the question comes, how did this occur? So I tell them that there are two ways in which endophthalmitis occurs. One is by what is called exogenous, that means from the outside, which in your case is extremely unlikely, because you see, we follow these fumigation guidelines, and these bottles are all new, there is no reusable stuff, and these are from the best companies, and our autoclaving is like this. So I give them, whether they want it or not, I tell them everything about how OT protocols are. So exogenous is very difficult. The other thing is endogenous. Sometimes the stomach has got bacteria, your teeth have got bacteria. It could come from. So plant the seed of doubt right from that time that it need not be from him. He could be responsible for endophthalmitis. True or not, we don't know. Maybe 5% is endogenous, 95%. I have not quoted percentages. I told him that there are two types. So leading him to believe that it's 50-50 now. My protocol is so good, so now he feels that 95% chance it is from his stomach.
Yes.
Let him believe that. And then the steps to what next to be done is like what others have said. Yeah.
That's a fantastic point which sir said. Make him believe that he may be diabetic, immunocompromised, and also tell him that there are so many components we use during a cataract surgery. We use BSS, we use so many things basically, and there could be a problem anywhere which we cannot tell you immediately now. We use the best for you. You can show him everything and say we use world-class stuff for you, but still something has gone wrong. And tell him that I'm doing my best for you. We hope you do well.
So what I do is I tell them, there is a infection, it's rare, it's very rare, and but it's there, everybody will get. If you operate, you are going to get at least one. So I tell them you have an infection in the eye, so you will need probably injections and surgery if it doesn't get cleared. I will be referring you to my retina colleagues who will take a sample, test and take care of you. So you have a VR surgeon, a patient comes with endo. What do you tell them?
Again, same thing that we tell them that it might be an inflammation or it could be infection, and then we need to do the testing investigations and then start treatment. What is most important is that you must inform the patient that time is of essence and everything has to be done very quickly. So there is no time actually to sit and dilly-dally. So you have to immediately also show that you are also concerned about the patient's outcome, and you also should not waste too much time in sending the patient for various tests and all. You must AC tap and intravitreal injection has to be done as early as possible, and then explain to the patient that we have to see how it responds and how it goes. But make sure that patient understand that this is it might require further.
Sure. So we have a lot more questions. We are running short of time, so we need to run a little faster. You have. Sorry. Teeth. Yes. Yes, so you need to tell them to actually do your dental treatment before a cataract surgery. I don't know, if they ask me, can I have a tooth exam treatment done post-op, I say no. You'll have to wait for at least a month to 2 months before you can go ahead to do it. Yes. Okay.
Fantastic point, sir. Patients always, they want a dental procedure before or after the cataract surgery.
So you have a young patient with a poor prognosis. Nanshi, you can take this. How do you break the bad news?
It is always better to explain right from the beginning the correct prognosis, because there is no point in giving them false hope that you are going to get vision and it is going to get better or anything like that. So be very frank and tell them this is the situation and the vision is poor, it is not going to benefit further or is not going to improve, and there is no treatment for this, etc. Like I am talking, say, for retinitis pigmentosa and all. So you have to inform them, but you have to also give them little hope that probably I tell them that lot of research is going on and maybe in the next few years we might get some solution for this. So we'll wait and see. But I tell them very frankly whatever is.
Yeah. So Dr. Badrinath always used to tell us that a patient has come to you. So what do? You first need to sit right at the eye level of the patient. Go close, pull your chair up next to him. We used to have a stool. We have a stool or a rolling chair. So you go and sit right at the eye level of the patient and tell them we are very sorry, but there is unfortunately nothing more that we can do. Your condition is so and so. If there is anything in future that comes in, we have your number with us, your MRD number. We will let you all know if there is anything further that needs to be done.
Yeah, again, difference between an institute and private practice. So what I do is I give them my phone number and I write down the words retinitis pigmentosa. And I tell them once a year on your birthday you give me a call. And just say you're a patient of retinitis pigmentosa, sir, you had asked me to call. So then they just ring up and say retinitis pigmentosa, you had asked me to call. So then I tell them if there is anything that so far nothing new, call me on your next birthday. So that
tell them happy birthday also.
Yeah, I tell them happy birthday. I tell them call me so that because I tell them you're young, I'm sure something will come up in your lifetime, may take 5 years, 10 years, who knows. But I encourage them to call so they keep that hope still there.
Yeah, so what I tell them, if something something new is going to come, it will be splashed all over in all the papers.
Also add a word about
some rubbish is also splashed in paper. So I tell them to call me.
I think we also need to tell about the rehabilitation process and low vision aids. So that is now possible. LVA kids and
much better now.
We need one point I'd like to add on. These patients are so desperate. When you see PSC with an RP, they advise cataract elsewhere. They come to you with a cataract. They say, doc, we'll be all right after the surgery. Please, again and again, we must tell the patient, no, we are just treating your cataract, not the retinitis pigmentosa. Because they expect miracles from us, which is not possible. So it has to be very clearly told and a consent should be taken for it.
And after the cataract, the vision which is lost because of cataract will come, your sight vision in a retinitis pigmentosa will not improve. That is a progressive disorder. But you're lucky that even at 50 your vision is good, so unlikely you may go blind, but you may need help to move around, cross the road or whatever it is. So for the retina people again, so same thing like you have for us also. We have developed the suprachoroidal hemorrhage on table, or you have a VR surgery which had to be abandoned in a one-eyed patient. So how to best explain to the patient? What are you going to tell them?
This is a little bit tough situation, but most of these patients from the, as I say, pre-operative counseling is the most important, because many of them would have had some very difficult situations to deal with. So always inform the patient pre-operatively that these are the problems that can occur. And post-operatively, you have to again inform them that yes, look, we tried our best. We have to we have to struggle quite a lot, and generally the surgery goes on for 2-3 hours, but despite that it could not be done.
So you come out of the operation theatre, you call the attendant and then tell them. So you tell the patient first, you tell the attendant first?
That depends. Generally I don't tell the attendant separately, I tell both the patient and attendant the next day morning in the OPD after seeing the eye.
I think it's always better to have the patient and attendant together and then slowly break the news, right? So first something we can do, right? So give some hope and then break the news that what step you are going to do for that. So that would be the best approach.
Say after every cataract surgery, do you talk to the patient's attendant also?
Yes.
So
before discharge, we tell them your general condition is good, surgery went on well, yes.
The surgeon talks. So in this case, so you had a suprachoroidal in one eye. What would you tell them that day?
Tell them there was a unexpected problem during the surgery. So at present we have closed the eye. We'll ask the VR surgeon to look at his eye either same day or tomorrow. Luckily we have an in-house VR surgeon, so he will visit at that time.
Will he be able to see? That's the next question. Will he be able to see?
No, we buy time because we'll see how the patient behaves. Let us take care of the blood pressure, the other issues, and see how he comes out of it. So we need to buy time and also keep advising the patient on the other care parameters.
It's how you talk slowly, talk softly, or talk not softly means talk clearly, but talk slowly.
The step-by-step approach helps.
Makes the patient sit
and always let the patient know you're doing your best for him. Most important.
Yes, most important.
And many times these patients who are abandoned surgery, when they come to the OPD, they will ask the junior doctor or the fellow who's posted with you about the prognosis and all. So in this situation, I tell the juniors not to talk, and it is best that the surgeon himself or herself explains.
So all of us will have corneal edema in at least one or the occasional cases. So what do you tell the patient?
Show them on the picture. You got a little bit of water in the cornea, it will absorb in the next few days, you will be fine.
Okay.
Yeah, I tell the same thing. I tell them it's like a fog on the glasses. It will go off as soon as possible.
Okay.
Being a corneal surgeon, I get patients referred because somebody has done a cataract and they've missed a Fuchs, and now there is a corneal edema. The problem is that the operating surgeon has not told them about the Fuchs. It's very obvious because the other eye I am seeing classic Fuchs, and they have not told them about it, and there is corneal edema. So how do you tell them without protection? So what I tell the patient is that, look, your cornea inner lining is a little weak, and your surgeon has done the best to protect the lining when the surgery was done. But sometimes because the inner lining is weak, the cornea tends to fill up with because I tell them that there are water pumps in the back of your eye which is pushing the water in. Your pumps are not so efficient. So water logging is taking place. So we'll wait and watch. In most of the cases, this water logging should clear with the medicines that your eye surgeon has given, because the eye surgeon has already put them on some salines. Yeah. So in case it doesn't clear, then we'll see what to do. But there is the very easy technique, which is where we change only that inner lining. Rest of the cornea doesn't have to be changed. But we'll cross that bridge when we come to it. Let's just now give it a good try with medicine. So I tell them nothing about the other eye. I just tell them about this. Yeah.
Yes. I have had instances where I haven't told the patient that his cornea was weak, and after the surgery, when they develop corneal edema, they get very anxious when they're not able to see. And then when I start them on hypersol, we have to wait. And again, it's reassurance. I tell them, don't worry, it will clear. And ultimately, when it clears, they are quite satisfied.
So I tell them you have a swelling in the cornea, and that should clear with the medicines that we are giving them. This is so important. You have an unsatisfied patient. How do you address the patient's concerns? Say when you have a patient, you prescribe glasses.
When you prescribe glasses for the patient, and when you have an unsatisfied patient, you call back the patient, you sit and talk to him, recheck his eye power first, find out what his concerns are, because you're the doctor, you dispense the glasses, somebody else, you sign the prescription, somebody else gives the glasses. Make him sit down, talk, first find out what his problem is, re-refract him, most important, and find out if he has been prescribed the correct prescription. And in case Suppose if the glasses match, for example, I have had a lot of patients with progressive lenses where the marking is not, the interpupillary distance marking is not very correct. So the patient tends to wear the glass a little up or down, and he is totally out of focus. So he says, doctor, your optometrist is not giving the correct prescription. So they coolly blame it on us. So it's so important that you visit the patient, you make him wear the glasses, and you tell him that, that there is an issue with this, with the glass, and tell him that you have to wear it correctly. And sir will add on the other points.
Yeah, no, the issue is whether you have an in-house optician or the patient has got the glasses made outside. If it's an in-house optician, it becomes easier because you can always take it back, and if you made a mistake, you can get new glasses made at no extra cost and give it. The problem is when you have spent 15,000 rupees outside on a pair of glasses with your prescription, and that optician there has said your doctor has given totally incorrect glasses, that's why you can't see. So then you tell him that as he says, the centering sometimes is not adequate, the IPD is not correct. So all this you need to investigate at your level, and then you write a note back to that optician saying that it is not
the centering.
That is one issue, because nowadays glasses are so expensive. The high-end glasses are so expensive, and if it goes wrong, patient has to pay a bomb.
And more expensive than a cataract surgery.
Exactly.
Which is very strange.
Yeah. So the patient has to replace. Patient will again think twice to repay.
They don't need sterilization also. They don't, even if they are dirty, it's okay. You can just clean them. So you have a cataract patient who has good vision post-op, but keeps complaining of irritation and watering. How do you reassure the patient? I'm sure all of us have this.
Yes. Most of us will have this, because dry eye patients, and so we need to first check the eye. So we have to ensure that we didn't miss anything. And then if know the cause, tell them it's an age-related problem. It is got aggravated maybe during this time, summer season or whatever it is. Then it will take care of it. There are a lot of good medicines available now. So we'll give that, and you will be fine in a few minutes.
Yeah.
Just go through the slides.
So we'll just run through the
slides, please.
Questions now. The next is this photopsia.
Yeah.
So
again, tell them it's temporary. In most cases, it will go away.
I tell them only the very intelligent patients see it.
Oh, exactly.
I tell them that. I said everyone has it, but you're very sensitive. You're probably one of the most intelligent people.
I tell them
you have seen it. Give it time, it goes away.
I tell them previously cataract was blocking that. Now you are seeing better.
So I'm just running through the questions for paucity of time. Decentered IOL. With good vision and with poor vision. So you have to be truthful. Basic point is these scenarios are to be able to tell the patient that we are truthful, that your part of your lens is moved to this side, but we need to.
It depends if it's got diplopia or not, and handle it.
The same with the refractive surgery, refractive surprise, or a patient who has poor vision post-op. Say you had a cataract where you couldn't see a macular hole. You don't know since when it is there. So you just need to be truthful.
This you nip in the bud. You, as soon as he starts complaining, tell him stop. You not come to me for complaints. You come to me for your eye problem. I don't want to hear this.
We had a patient together. We had a patient.
Never let a second person come and backbite about an ophthalmologist to you. You need to support them.
Exactly.
If you have nothing, you have to take that message home.
Yeah, we had a patient, one classic, other was ICL, and fellow, he was from the US, used steroids indiscriminately, came back with an early cataract, high pressures. I referred him to Vineet, and he was just complaining. He said some other fellow.
He basically wanted a free cataract.
Yeah, he wanted a free cataract surgery. That was the end actually.
Yeah.
So any patient can be handled, no problem at all.
What about an aggressive patient? How do you calm them down?
Just hear them out. So the first 2 minutes is crucial. Sit them, make them sit. So have one staff with you, and then hear them.
Don't let
once they are exhausted with that anger and use of words, then try to explain.
Exactly. First exhaust him out, then
I tend to agree with him. So when he's aggressive about something, I tend to agree with him. I said, in your place, I would be equally annoyed equally.
Absolutely.
So empathize, show that empathy with the patient. That if I was in your place, I would also feel like this, but let's see how we can move further.
Yes. So I'm just running. This is another important thing.
Yeah, I have handled this in the sense that I've had a death on table. Not really on table. Luckily for me, the patient came out, said hello to relatives, and then died. So it's just one of those things. Within 5 minutes of coming out with an anesthetist in place, everything, and no matter what we did, we couldn't revive. We had a cardiologist coming in 5 minutes, but the patient died. He was a poor risk, but the risk had been explained to him of death on table had been explained to him. He had come from Indore to me, and he had been told in Indore, and he had been told by us. We had spent almost an hour before the surgery, anesthetist, myself, and the patient's relatives. So they didn't blame us, but there is a procedure. Don't get scared. Please call the police. Have, at least in Maharashtra, we have something called a panchnama, where there are 5 witnesses, and the police record a statement, and then it goes for postmortem. Don't short circuit this. Don't put any bribes anywhere. Because maximum what you can do is that you can, if the patient has paid you for the services, if you want, you can refund that, but that's also not mandatory. I gave the patient money so that they could take the body back to Indore. That was just part of the fees that he had already paid to me, not the full. But don't panic. It is not your fault that the patient has died. Patient has died because the patient was destined to die.
Yeah, we are done.
Okay.
So just one last, we'll skip all these. This is important. Vijay keeps handling a lot of VIPs. How do you handle a VIP patient?
Yeah,
They are dangerous.
unknowingly or unknowingly, I have a lot of VIPs in my practice. I see a lot of them. Now, I'll just tell you a few points how to handle these VIP patients. I mean, first of all, when you see these VIP patients, be careful. Okay, go with the red flag, because they come to you with a lot of, they come to you with lofty expectations. They want the world from you. So make sure that first, when they come to you, most important, make them comfortable. Don't make them wait. They don't like to wait. So, as soon as give them a time where you're comfortable to see them. Come and see them, and make sure that you're careful. And third, make sure that you're with a clear conscience. I had a VVIP patient, a former union minister, who came to me into my room. He said, Thambi, when I read in the parliament, I must read without glasses. I want a multifocal. So we did all his tests. He had a compromised retina. So I said, sir, we can't do it. I mean, sorry, we cannot put a multi for you. He said, no, I only want a multi. We had a big argument. I said, then I'm not the guy for you. I'm sorry, go to some other doctor. He relented, had his cataract, and he was extremely happy. So it's very important that you have a clear conscience. Never compromise for his or her, for their expectations, their happiness. And the other most important thing I want to say is, communicate very well. See, a lot of these VIPs have a lack of communication. They can't communicate very well. So they'll have an attender with them. Please speak to the attender and tell them this. Please make sure that this is a lens I'm going to put. And if there's a compromised retina, they have an ERM. Please make sure that you tell them. And the last point I want to emphasize is confidentiality. Please don't take pics and put it on Facebook and this guy came, that guy came. Please don't do it. You're hurting him and yourself. He's going to have a very low opinion about you. So please don't do it. And these are the important principles I follow when I say VIP patients. Thank you.
Just one point to be added. Please document all those things.
Yeah, extremely important. Documentation.
Thank you all. I'm sorry we overtook the time, and we had a nice discussion. Thank you.
Yeah, we have a group picture. Arun.